Hi guys, Dr. Gillard here once again. Welcome back to our continuing series on embryology. We are on video 5 now. In this video we're going to focus on the formation of the notochord. We haven't quite finished week number 3, so we're definitely going to finish week number 3 in this video. There is some overlapping story going on at the same time. That's why it's so hard to teach embryology, because so much stuff goes on at the same time. Specifically gastrulation, mesodermal differentiation, and somite formation is going on at the same time. We'll talk about these important processes in the next video. But right now we're just going to focus on making a notochord. Right, and just some kind of refresher anatomy where we've been. We've taken a bilaminar disc in the last video during gastrulation and created a trilaminar disc. And here, this is a cut right through the midline, and so we don't see much of the new mesodermal tissue that we formed in the last video because we have to leave room in the midline to grow a primitive streak right here, or I'm sorry, to grow the notochordal process. But we do have the primitive streak kind of drawn in here. This is a sagittal, mid-sagittal view. If we went to a parasagittal view, we would see mesoderm squeezed in here between these two layers, the ectoderm and the endoderm, but not in the very midline cut because we're going to have some room here. All right, and remember in our previous videos we talked about how a prechordal plate formed with mesodermal tissue. That's considered mesodermal, anterior mesodermal tissue. And then way back we talked about the AVE cells, the anterior visceral endoderm. They're part of the endoderm. And that's about it. I didn't draw in the oropharyngeal membrane, which would be above here, and the cloacal membrane would be here. So this first part of the video, we're going to grow a little stick right out between these two layers of ectoderm in blue and endoderm in yellow. I think there's a little stick. I kind of drew it in there in Photoshop. Okay, so that's what we're going to be making, this little stick right here, super important, called the notochord. Let's see how that is done. The final product is often called the definitive notochord, or the final notochord, or just the notochord. But it has a precursor phase called the notochordal process, which we have to develop first. Okay, it's developed slowly in the from newly created ectodermal cells that migrate, as we'll see. It takes about 6 days to form, and it's not a permanent structure. It's going to disappear except for some of its resin, the very tiny last part of it that doesn't disintegrate is actually used to form the nucleus pulposus of the intervertebral disc. All vertebrates, humans are vertebrates, and all vertebrates have a notochord, whether it be permanent or not, and that makes them members of the phylum, which is the general category chordate, which humans are a member of this phylum chordate. It extends from the primitive node to the prechordal plate. So here's the primitive node of the primitive streak right here. So it's created by cells migrating through the primitive node and then going in the midline straight forward, and they bump into the prechordal plate, and that's all the farther they can go. So those are the two structures it's perform. It's where you can find it. Okay, as it grows too, the primitive streak is going to regress or shrink in size. So that's how it continues to grow backwards caudally. So first it grows cranially until it bumps into the prechordal plate, and then it grows caudally as the primitive streak regresses. I have to do a rant here. This is a horrible mess with regard to the authors. They're all over the place with telling this story. Two major chiropractic board of examiner books that are used to make questions. Moore and Langman are conflicting, do a terrible job of telling this story. Singh, who's not one of the major authors, but he's a pretty good storyteller. He does a good job. Larson does a really good job of telling the story. And Carlson does a good job of telling it as well. Okay, so no wonder medical and chiropractic students don't understand embryology that good, because no author has really told a good story. Basic functions. So what does this notochord do eventually? It provides a axial support for the growing embryo. So it's like a little spine. Think of it as a little spine, because we got our trilaminar disc is the little human, and it needs a little support. So this notochord gives it a little bit of support. The axial skeleton is going to take over this duties, but for the time being, it's like a little spine of the little tiny human. It also induces the formation of an incredibly important structure called the neural tube, we'll talk about in a little while. What does that mean, induces the formation? That means it turns on genes in itself, and it releases proteins, growth, transcription factors mainly, and those transcription factors turn on genes in cells passing by, or turns on genes in the ectoderm above to create the neural tube, as we'll see. So it induces the formation. In other words, it causes the cells to turn into neural ectoderm cells, as we'll see in a little bit. Primitive node helps as well, as we'll see. It induces the formation of the vertebral bodies, and as I just said, after it disintegrates into almost nothing, the very remnants of it are used to create nucleus pulposus tissue. They turn into cells that secrete the proteoglycans of the nucleus pulposus. And interestingly, these notochordal cells that created the original nucleus pulposus, they disappear and are replaced by fibroblasts at the age of 10. And this can be problems, as we'll talk about here in a while. Here's the intervertebral disc, right? This is an overhead view. There's the posterior arch. There's the lamina, spinous process, superior articular process, inferior articular process, right? The spinal cord would be right in here, or thecal sac, or dural sac in the lumbar spine. But here's the disc. It's got two parts, a nucleus pulposus, which up until the age of 10, the cells population in here is the notochordal cells, and they secrete proteoglycans. And then to keep this, it's about 80% water. To keep this in place, because we have the axial load of the body, pushing down like this and squishing this like a grape. So to strengthen it, we have these about 20 rings of super strong type 2 collagen called lamellae, and these 20 lamellae make up the annulus fibrosus. All right. Here, this is a mid-sagittal view. You can still see the nucleus pulposus and the lamellae, which actually completely encircle. The author didn't show these. There's a vertebral end plate here, and they circle through that. All right, so the first step in making a notochord is making its precursor, which is called the notochordal process. And this starts from a second wave of these weird mesenchymal bottle cells. Remember, the epithelial cells go through the primitive streak and they turn into like a bottle or flask-like cell, which is a mesenchymal cell. It grows little pseudopodia, so it can crawl and actually move. So the first wave, as we'll recall, made the prechordal plate. So after the prechordal plate is formed, another wave of cells migrates forward, goes through the primitive node and primitive streak, and mainly through the primitive node, is transformed there, and it migrates forward to form this notochordal process. So it stays right in the midline. Again, it's between the endoderm and mesoderm, just like the cells that went forward to form the prechordal plate. And what else do I need to say here? The cells, as I kind of said at the beginning, the cells can't go all the way. They bump into the prechordal plate and start to pile up backwards toward the caudally. And that forms a solid cord of these cells, and that's called the notochordal process. Some authors call it the head process. So here's a cartoon. Primitive node is not drawn very well, but it would be a more raised region here. But all these cells are moving into the primitive streak and primitive node, and they get transformed and they spit. Instead of going to the sides like all these mesenchymal cells did to make the mesoderm, these ones go straight forward. And this mesoderm is being made at the same time. This story is all going on together. So we got this stick of cells going forward, and that's the early notochordal process. Here's another mid-sagittal cut, and you can see better here. Here's a notochord, or here's the primitive node, and there's the primitive streak. And it doesn't show the cells migrating, but the cell from coming laterally, but the cells laterally come into the primitive node, and they are converted. It doesn't show bottle cells, but they're converted into those flask-shaped bottle cells, which turn into mesenchymal cells with pseudopodia, and they can literally crawl forward until they bump into the prechordal plate. And that's your notochordal process. Now, how does it keep growing if it bumps into the prechordal plate? It's because this primitive streak shrinks. So in the next picture, we will show this is gone and that everything is shrunken backwards and the primitive node is moving backwards. These cells just keep getting spit out the front here, and that causes the lengthening of the prechordal or the notochordal process. So what really induces the formation? How do you tell these cells right here, these guys, how do you turn them into notochordal process cells? What do you have to do to these cells? They're moving in. What do you have to turn on to make them go straight forward and not make them go to the side and become mesodermal cells? You have to flip some switches on these cells. And so these switches, there's two big genes. There's the FOXA2 gene called the forkhead box protein A2 gene. That's got to be turned on. In fact, these cells right about here, that FOXA2 is already turned on before it even gets. So we're not exactly sure. It's not the primitive node that's turning this on, we don't think. So they're not quite sure what turns it on. Maybe some transcription factors have leaked out of the primitive node into this region. It's hard to tell where it came from, but they're definitely turned on. So FOXA2 gene is turned on. It has to be turned on or you get some wicked birth defects, which I don't know if this kind of beyond the scope of this series to talk about, but it's an important gene. And then as they migrate through and migrate forward, there's a gene that protects them from deviating to the left or right and becoming mesoderm cells. And that's the brachyury gene, or the T gene is an common AKA for this. That gets turned on when they go through the nodal cord. So the T gene gets turned on once these cells, FOXA2 is on here. Once they migrate through here, the T gene gets turned on, and that protects them from wandering and keeps them focused on going straight ahead. Okay, everybody good with that? All right, we talked about this, how it elongates already. Once the stream of cells bumps into the prechordal plate, they can't go forward anymore. So they start regressing backwards as the primitive streak starts shrinking. So as the primitive streak starts regressing, the primitive node is still spitting these cells out, and therefore it expands going backwards. Okay, so therefore technically the nodal cord elongates in a cranial to caudal direction. It initially forms in a caudal to cranial direction, but once the cells bump into the prechordal plate, it elongates in a cranial to caudal direction. That's a good test question. Be careful of that. So here's that same drawing I showed you before, but now most of the primitive streak is gone because it's shrunk. But in the meantime, the cells, they've bumped into here. They can't go further this way, but they just keep filling in backwards, and that elongates the notochordal process here. Everybody good with that? Okay, then we get this weird phenomenon. The notochordal process becomes hollow, which forms a lumen, and that lumen is called the notochordal canal. So this is, we're kind of maturing, building the final notochordal notochord. So to do that, we need to hollow out that cavity to form a notochordal canal. Okay. So here, let's hollow it out. So that's the first thing. Cells get sticky and they stick up to the roof here. The basal lamina is right here. The basal lamina of these are ectodermal cells. And then they stick down here to the basal lamina of the endoderm. Okay, notochordal canal. Next, what happens? The notochordal process is going to fuse with the underlying ectoderm. So these cells are going to fuse very tightly with these endoderm cells. In fact, they're going to be squished out of the way and only be up top, as we'll see here in a second. Let's see the picture. So most of the cells are morphed into one single layer here, and these start shrinking as well. In fact, they're going to shrink so much that we're going to rip a hole in the basal lamina, and there's going to be no cells here, and we're going to create a new canal. And that picture I showed you back at the beginning, remember what's above? That's the amniotic cavity, right? Not shown. Secondary yolk sac is right there. So we're going to develop a communication between these. So if you're a little tugboat and you're floating around in this fluid, this secondary yolk sac, you can actually drive your tugboat right into this new lake up here, the amniotic cavity, if you will. Got ahead of my slides a little bit. So that canal is called the Neurenteric canal. And as I just said, the fusion of the ventral portion of the notochordal process and the underlying ectoderm destroys both layers, creates a communication, and then you can a communication between the secondary yolk sac and notochordal canal and the amniotic cavity. And that's again the Neurenteric canal. And it doesn't stay very long, but here's a cartoon of that. So endoderm cells are completely gone here, and we got a nice canal. Okay, but this is not going to, the body's not going to stand for this. The little human is going to start growing new endodermal cells to seal this off, and we're going to see what happens as that the effect of that healing process. So next, we got to plug this hole. So these cells are slow growers, so they can't plug it, but these cells can drop down from the top and plug this hole, and that's exactly what they do. So the notochord is no longer really a tube, it's going to be a flat plate, and that plate is called the notochordal plate, and that plate shuts down that canal. That Neurenteric canal is closed by the notochordal plate. It's like a band-aid over it. So here all the cells have dropped down and they've plugged the hole right here. These endoderm cells are still growing in. They're growing in from out of the plane of the page as well to close this. Not just this direction, but they're growing because we can't see them all. This is just a slice, a mid-sagittal slice here. We can't see the ones that are deep to the plane of the page and out of the plane of the page. So I got a picture of that. And so here, let's go to a head-on view, a coronal view here, and we can see we had a notochordal process. It hollowed out. It fused right here, and that caused destruction of both of these layers. This red line is the endoderm, and this is our notochordal process, and it caused a breakage. To plug that, all these cells dropped down and formed the notochordal plate. And now, as the endoderm cells are regrowing and pushing in, it buckles this plate upward. See how it buckled it? And then pretty soon we're going to have another hollow structure. So we have a notochordal process canal is probably a better way to describe that one. And now we're going to have a notochordal canal. and then simply might as well finish it. These cells are going to, by mitosis, are going to multiply and fill this tube in, so we have a solid, definitive notochord, our final product there. Got ahead of my slides again, but never hurts to go over it again. So again, the cells grow in, the endoderm cells grow in, it causes an uplifting of that notochordal plate, and it forms another tube, and that tube simply fills in with new cells, and we have created the definitive notochord. Great. Notochordal pathology, we should talk about this. Notochord remnant versus low back pain for chiropractors and people who are going, and primary docs too. It's important to understand the theory of chronic back pain, one theory anyway. So as we said, around the age of 10, the notochordal remnant in the nucleus pulposus completely degenerates. So the notochordal remnant gives rise to the nucleus pulposus. Those notochordal cells stay in the middle of the disc, and they spit out proteoglycans and they make the disc. But they don't stay around forever. They disintegrate completely about the age of 10, and they're replaced by a weird fibroblast, like kind of a mesodermal type cell, which doesn't do a great job at secreting proteoglycans. That's why degenerative disc disease is so common in humans. Decreases proteoglycan equals decreased water content. But anybody see a problem? Think of your immune system, how that was formed. Anybody see a problem? Well, who are these new cells, these fibroblast cells that show up? Remember, when your immune system is forming, when you're a fetus and an embryo and fetus, it's like I tell my students kind of this story. It's like your immune system is powerful. It can attack and destroy viruses that invade into your body, or bacteria that invades, or foreign tissue that gets in, like a sliver gets in your tissue. So it's an attack force in your body, but it has a list, because you don't want it attacking your good tissue, right? Your quote self tissue. So it has a list of self, and that list is created for the most part during development. And so your body's going along, and your immune system is going along making its list, and the heart is formed, and it goes, okay, check, these cells are all part of the heart. Your liver's formed, okay, check. Don't attack these are liver cells. And brain, check, don't attack your brain. Here's your eyes are formed, check. And then when your disc is formed, it checks the annulus fibrosus. Oh no, thank you. I wonder why that came up. So when it comes to the disc, it sees these notochordal cells in the center of your disc and goes, okay, check, that's self. And great, so the baby's born, everything's good, but by the age of 10 years, those notochordal cells are replaced by these weird mesenchymal cells, and the immune system isn't checking things anymore. So those aren't, and this is the theory, that's not part of self anymore. Which is fine, because the nucleus, the middle of the disc, has no blood supply. All right, we're going to learn that in our spinal anatomy class here in a bit. So everything's fine. The body can't see them anyway. But what happens if you get a rip through the annulus fibrosus, and those new fibroblast cells drift out into the periphery of the disc through this rip, which is called an annular tear? And once they get in contact with the blood, your immune system lives in the blood, right? And the immune system sees these weird cells, and it goes, wait a minute, let's look at our list. There's nobody on the list. Sorry, I don't know why this is coming up. So it goes, okay, this is a virus or some weird cell attack, and it does that. It attacks it, and you get a wicked inflammation going on in the back of your disc. And where those blood vessels are, so are the sinovertebral nerves, aka recurrent meningeal nerves, and you get a chronic, horrible back pain. Some people do. And that's called discogenic back pain, which is the number one cause of chronic back pain. And chronic back pain, that's not That's not pain that's been there for a couple weeks or a couple days. You pulled a muscle in your back or something. This is pain that's been there for greater than 3 months. Number one cause is an annular tear in your disc, according to Bogduke. So here's the scenario. So let's say this is a 40-year-old man, and the notochordal cells are long gone, but they're hanging out here. The blood is out here in the periphery, and the nerves, I didn't draw the nerves in, but the nerves are out here as well. But everything's fine. What happens if we get a rip? Let's say he lifts a 100-pound cement bag, and he rips the annulus, and these cells can go right through the rip. Once they get out here in the blood where the body's immune system is, the body goes, oh, wait a minute, who are these guys? They're viruses, and it attacks, and you get almost like an autoimmune attack of these weird fibroblast cells. And I didn't draw the nerves, but the nerves are infested in here, and it triggers what's called discogenic pain. This patient has horrible back pain, causes a reflex muscle spasm, so maybe he bends to the left or right depending where the tear is. So that's discogenic back pain, all because of the notochord. Here you can order a test for that when you get out and get your license, called provocative discography. And here's one of my patients not too long ago who unfortunately had a symptomatic annular tear. They stick a needle in the disc, they fill it up with dye, and normally you should see the nucleus because it's corralled like this region. You don't see any dye leaking here. But this patient had a big tear right through the disc right here. And here's all the dye. It's leaked out there, and it's also leaked out here. So he's got a double tear in the disc. This disc is shot. This is the overhead view we just looked at. Here's from the coronal view, or mid-sagittal view. And you can see the tear here in this disc, and there's another tear in this disc as well. And in fact, this disc's grade 5 tear, it actually leaked. This is all dye that's leaked out. The disc has sprung a leak. So discogenic pain. I digress. I apologize. What happens if all the nodal cord or a big chunk of the nodal cord doesn't degenerate away? That is a big problem. So a chordoma is a rare tumor that arises from remnants of the nodal cord that didn't go away. This nodal cord can turn into different types of tissue, and this is cancer in a good chunk of these tumors. Luckily it's super rare. 0.0001 is the prevalence. That's probably the incidence, actually. No, that is the prevalence. Rarer than Marfan syndrome is 0.01. I don't like to talk about conditions that are rarer than Marfan syndrome, but this one, I mean, we're talking about nodal cord, so this is a nodal cord that didn't regress with the passage of time. It accounts for about 2% of all malignant bone tumors are the result of a persistent nodal cord, and they're these chordomas. They typically show up in the cranial or sacral region, show up symptomatic in males around 50 or over the age of 50. 30% of the chordomas are malignant, so they're not always malignant when they form. The cranial ones have a tendency to form in the nasal pharynx, and they can look just like a polyp. So it could be cancer growing, and the ENT doc looks up there and says, it's just a polyp, don't worry about it. It wasn't a polyp, it was a chordoma, and the patient dies from it. So here's the axial overhead. You can see the eyeballs here in the nose, nasal cavity. Here's a really big malignant chordoma that's grown in this patient who presented with headaches. So yeah, it's not good when they don't go away. All right, so that was the story with formation of the nodal cord. I'm not sure if I'll put these together, maybe make a separate one. So I'll say goodbye for a second, and I'll be right back in another video, or I'll keep going with this one. So let's go on to talk about neurulation.